Good morning. I now have the pleasure to introduce the speakers of our Patient Advocacy Spotlight. No stakeholder group is more important than the patient in the design, the development, evaluation, and deployment of our mHealth solutions. We have two exceptional presenters this morning to give the patient perspective on mobile health. Our first presenter is Donna. Donna is the president and CEO of the American Liver Foundation. She's the first patient to lead the organization in its 30-year history. She has a diverse experience in law, public relations, and patient education and advocacy. And she currently serves as a patient representative to the Food and Drug Administration. Our second speaker will be MaryAnne Sterling. MaryAnne is CEO of Sterling Health IT Consulting, specializing in information technology, health policy, and communication. MaryAnne serves as executive in residence for the HIMSS Foundation. She has volunteered for the Alzheimer's Association and serves as ambassador to Senator Mark Warner's office for the implementation of the National Alzheimer's Project Act. So join me in welcoming our first speaker, Donna.
Good morning, everyone. I am very excited to be speaking with you this morning. I'm very honored as a patient and patient advocate and the leader of a patient advocacy organization to have the opportunity to speak with you this morning on this very crucial topic to healthcare, connecting the mobile health ecosystem to patient advocacy. I think the theme really for this entire few days that we'll spend here in the National Harbor is about connectivity. Connectivity, whether in technical terms or in the very human terms that I would like to spend a few minutes with you this morning. Often I hear mHealth strategies about consumers, really everyone, all of us. And I think that using that construct of consumers is actually a barrier to the implementation, or at least to setting the expectations about implementation of many of the mHealth tools and technologies that are featured throughout this conference. And so I really want to have you take away from my presentation understanding of patients, e-patients, patient advocates, patient advocacy organizations, and as my colleague will speak following me, about caregivers. So I'd like to do this in a very non-techy way. There are no numbers on my slides, and not because my tech people or graphics people told me I couldn't have them. I thought deliberately no numbers. There will be some mentions of some tech incubators and companies, but I really thought that I would present this story as a romance. So come with me if you will. So connecting mHealth to patients and patient advocacy organizations is about bridging patient cultures. Connecting e-patients even to patient advocacy organizations themselves, you may not imagine, is also a bridging of two very different patient cultures. I feel very privileged and honored to live in both worlds, to be DC patient on Twitter and in my blog, and to be the CEO of a very traditional patient advocacy organization and a consultant to many before that. And so when I thought of how to explain the two personas to you, any of you who are in fashion, I thought, well, the e-patients are sort of like Betsy Johnson. They're wild, they're new, they're eclectic, they're energetic, they're engaging, but they're also very fragmented. Who is an e-patient? How do you find them? How many of them are there? What does it take to qualify as an e-patient? How would you work with them or connect to them if you did want to? And then the traditional patient advocacy organizations, if I were to create them in human form, I would think that they're sort of like Ralph Lauren. You know, they're well funded, they're a little conservative, they have infrastructure, procedures, lots of procedures, staff. That's a great asset that that the traditional organizations have, they're very trusted by their communities as carriers of messages, as a stamp of approval on things that are new, they're connected. Many have databases, as we do, to thousands, if not millions, of patients. And so while the e-patient movement is looking for structure and trying to mature to the next level, and what does their governance look like, the traditional patient advocacy organizations have nothing but governance and structure and things. And so I think that through this I propose a marriage. So the implication for e-health is that the advantages of the e-patient movement are early adoption of new technologies, rapid dissemination through social media. They're also highly critical, which I would pose is a very good thing for you, because you get this very knowledgeable feedback very quickly, sort of a lean startup type of feedback that's necessary for you to get to that next iteration of an mHealth technology and to make it better. So there's so much value in the e-patient community. There is a lot of value in the traditional patient organization community. There is an education process, there are review processes that provide credibility, there are opportunities to do pilot studies, clinical trials, translational studies, surveys to large groups of people. And we are also, and very rarely have we been thought of as a channel marketing partner. So having participated in a lot of demo days and mentoring some companies coming out of tech incubators, they're always looking for channel marketing partners, or at least they should be. But they're not thinking about the traditional patient advocacy organizations who do have access and who are piloting new programs annually, if not more frequently, and can really be a great conduit to having more people aware of and using your mHealth solution. So, in this marriage, in this lovely marriage of our Betsy Johnson wearing e-patient and our Ralph Lauren Polo wearing traditional advocacy organization, there need to be rules of engagement. Bridging cultures is hard. Change is hard. Having people from different worlds work with each other is not an easy thing. As those of you who are trying to explain the need for mHealth perhaps within your own institutions or companies, there needs to be some rules of engagement. And so those that I think are really important, at least to bridging the cultural divide between patients and e-patients, are that, particularly coming from the foundation side, from the traditional patient advocacy side, we needed to invite the e-patients and e-patient innovators into our organization. They're not going to naturally come to us, sometimes rightly so. There are many organizations that's rather hostile to innovations. So we need to invite them in. We need to create forums where they know that they're welcome, that there's a place for them, that we want to hear these new ideas, that we are open. The second step, these sort of second rule of engagement, would be to engage influential champions. You know, who gets it within your organization already? And this is not a factor of age or even personal technological savvy. As I found on my board of 20, the support I got for new innovations and a case study I'll share with you in a moment was from a hepatologist who has been practicing literally as long as I have been alive. And he was my most influential champion and helped persuade others that this was something that at least we would try. The third rule would be to expose traditional stakeholders to e-patient potential using problems defined by traditional stakeholders. When I came into my organization saying we were going to be patient-centered and we were going to vet these mHealth options to integrate into our programs, there was a deer in the headlights look. So what does that really look like? What does that really mean? How can you provide demonstrations and examples as quickly as possible? And I found that the best way was to focus those innovations around answering questions that your board or your staff already cogitate on, already what keeps them up at night, and answer those questions first using these new tools, and I think you'll bring a lot of people on board. And then finally, to help meld those cultures and the needs of both that sometimes conflict, create a process that engenders the credibility and sometimes the very long processes, very bureaucratic processes that traditional patient advocacy organizations have, going through medical review and board review and layers of review, uninvented yet, but that do have the advantage of lending credibility. How can those work faster than normal? How can you create sort of a product cycle within a traditional patient advocacy organization that can actually move at the speed of mHealth? So this is what we've done inside the American Liver Foundation. We created an innovation council as part of our corporate roundtable, but a little separate, so that we could invite just creative people who had new ideas. And our strategic question as an organization was, how do you change healthcare to better serve liver patients? We really hadn't asked such a pointed question before. And we created specific questions, challenges, if you will. I know we're all in this room familiar with design challenges and innovation challenges and hackathons. And so we designed some challenges that would answer questions that matter to liver patients. So the Innovation Council was to create a platform to focus emerging technologies and innovation on problems that matter to liver patients, such as how do you accelerate a newly diagnosed patient up the learning curve to be an expert patient, so they understand their treatment choices and options about their disease. How do you do that better and faster, whether someone is in a rural area or in the middle of a city right next to a transplant institute? And we wanted to be able to facilitate the introduction of these new technologies to healthcare systems and providers. So it would really be a win-win. It wasn't just about us getting our problem solved. How could using this platform, how can using the assets of the organization help accelerate the adoption of the most promising technologies into actual practice? And so examples of some of the innovators that we invited in to present at our first Innovation Council was OraSure, or Quick. We know them for the rapid HIV testing, and there's also rapid HCV testing to help us increase and extend testing in a variety of settings. Inquisit Health came out of the Blueprint Health Tech Incubator in New York and facilitates patient-to-patient or caregiver-to-caregiver peer support in a way that's a great supplement to our live support groups, and also allows us to erase barriers of geography and time and connecting patients to the answers that they need. And Ginger.io, originally a connection from Pipette that came through the Rock Health Tech Incubator, helped us understand how we might be better as a foundation creating mHealth adherence support and risk prediction tools. And I'm really excited to say that one of our presenter from Ginger.io has actually been sworn in as a Presidential Innovation Fellow. So I really think, and all of these have either gone on to the progeny of this romance, the progeny of this marriage, if you will, have been contracts with the hospitals who attended the Innovation Council, or contracts or pilots with the foundation itself, or exciting new fellowship and design contests. So I think that the marriage of e-patient energy and traditional organization structure holds a lot of potential, and I thank you for allowing me to share that with you today.
Good morning. Before I begin my remarks, I have something very special to share with you this morning. I am a proud member of the Walking Gallery, and I want to share my story as captured by the wonderful Regina Holiday on the back of my suit jacket. So I'm going to take a moment and spin around so you guys can see this. This will give you some context into the remarks I'm about to make. As I was silencing my BlackBerry this morning, I was just thinking about how far technology has come in the past 16 years. Think back to the mid-1990s. We used to go to retail stores. Now we go to Amazon. We used to have cell phones. Now we have smartphones. We have willingly given up books for e-readers. And we have social media. Technology has evolved, and we have evolved with it. But there's been no such technological revolution for the family caregiver. And I'm acutely aware of 1996, because that's the year I was thrust into this role. 44 million Americans need your help. They are providing care to someone who is ill, disabled, or aged. These unsung heroes are right here among you. Family caregivers live among us everywhere, in plain sight. Maybe you or someone sitting next to you are like these family caregivers. My cousin Heather and friends Regina and Stan have cared for family members with cancer. My friends Mark and Adele each care for an autistic child. Karen was a longtime caregiver for her daughter who had a rare disease. My friends Phil and Linda, Ron and Dee have all cared for a parent with Alzheimer's disease. Sarah cared for both her father and her husband with Alzheimer's at the same time. Me and my husband Ben. We have 3 out of our 4 parents diagnosed with some form of dementia, in addition to other chronic conditions. We've been on the front lines for 16 years. Let's pause for a moment and think about who you know that's a family caregiver. Each one of them is part of the new normal. The family caregiver in the middle of the caregiving sandwich, often caring for their own children plus a parent or spouse with a life-threatening illness or chronic condition, and holding down a job. My professional career started in software development. The software development lifecycle is permanently etched in my brain. It is often represented something like this. Many of you are app developers and can relate to this. At each phase of the lifecycle, we need different information and tools to complete our work. The lifecycle concept also applies to caregiving. Family caregivers need information specific to the phase of caregiving they're in. For example, a caregiver may be dealing with a crisis, assisting a family member with a care transition, or in maintenance mode, just trying to navigate day-to-day challenges. I've developed a visual representation of this concept. We may find ourselves in each phase many times over the course of our caregiving experience. In addition, our information needs fall into 2 distinct categories: gathering information to act upon, and providing information to others. I'll highlight these as we go along. A crisis refers to an accident, injury, or new diagnosis. During a crisis, caregivers may need to provide information to healthcare professionals, such as the patient's allergies and health history, family health history, immunizations, test results, and health insurance information. Also during a crisis, caregivers need to gather information like diagnosis or injury details, disease-specific information, care options, and next steps in the recovery process. Care transition refers to a new care setting or new phase of recovery or illness. During care transition, caregivers also need to gather information about the patient's care plan, for instance. Okay, ideally the caregiver would have been playing an active role in the development of that plan. Housing and caregiving options like rehab and home health, community resources such as Meals on Wheels and transportation, how to perform caregiving activities, and medical equipment that might be needed. And finally, maintenance. This refers to a chronic condition or permanent disability. During the maintenance phase, caregivers are also busy gathering information about long-term care supports, financial options, assistive devices, medication regimens, respite care, and support groups. The family caregiver ultimately becomes the patient's care and services coordinator and frequently has important information to share with providers. Last year at this time, my 82-year-old mother fell and crushed her right arm. We pursued her admission to an inpatient rehab facility so that she could relearn how to complete her activities of daily living without the use of her dominant arm and hand. When they decided to discharge her, nobody bothered to ask about her living situation, her resources, or who would be caring for her moving forward. These are critical details. They eventually handed us 2 sheets of paper with 53 home health agencies listed. We had less than 24 hours on a weekend to figure out who to choose. My life would have been so much easier if I'd had an app that would show me the top 5 home health agencies in my mom's area and community services and supports that she might need. We do this everywhere else. Online, as evidenced by those retailers that are always telling me when I buy a shirt that I need these pants and scarf to go with it. Why can't we do this in healthcare? We all talk about public health crises such as obesity and diabetes. I believe that a large and growing public health crisis is the effect that family caregiving has on those providing care. Caregiving takes a huge toll on the physical and mental health of family caregivers, putting further stress on our healthcare system. Right now, too many family caregivers rely on informal and ad hoc streams of information from their own circle of friends, family, and colleagues, otherwise known as tribal knowledge. This is where you come in. You are in exactly the right place to help create a family caregiver ecosystem. You can lend your voice to help redefine primary care. Primary care is happening in the home. Caregivers must be key members of the patient's care team in all care settings. You can break down care coordination silos. We must align community supports and social services with healthcare. You can include the family caregiver in the conversation, educate them, train them, listen to them. You can rethink required patient data in your facilities. Record the family caregiver's name and their role in caring for the patient. You can help change attitudes. Make it everyone's responsibility to assist the family caregiver in coordinating both healthcare and support services. You can focus your innovation on the family caregiver. I'm here to tell you, my patience is growing a bit thin for arguments about privacy and security, arguments about who owns the data, arguments that the family caregiver is not a trained professional. We need to work together to figure out the intersection of mobile technology and family caregivers, and we need to make it work. There are 44 million people eagerly awaiting your help. Thank you.
Lights are coming up. So anything you've ever wanted to ask a patient or a caregiver but were afraid to ask?
We're here to help.
I can't see if there are hands raised. I'm being blinded, so I can't see it.
I'm blinded by the light up here, guys. Jump up and ask
So,
any question that comes to mind.
Shout it out. There are questions. You know, I'll start. I'll ask you a question. Or actually, I have a comment, because when you were talking about your need for somebody to help you sift through this list of home health services, I've been in that situation in my few instances as a caregiver. There's an app for that, or at least there's a company called Aid-In that, if they're not exhibiting here, happy to make that introduction. And I think that some of the fun of being a part of things like this is to be able to find solutions for the problems that we have as patients or caregivers. You know, one of the things is, you know, the recommendations that would tie in based on my presentation is to then to connect that solution for the problem that you had to the Alzheimer's Association with which you work, or to AARP, so that more caregivers and patients in the same situation can be exposed to that. I do see a question over here. Yes.
This question, I'm Keith McInnes from the Department of Veterans Affairs, and the question in some ways could be to each of you. I'm thinking of hepatitis C for a moment, and when a patient undergoes treatment, it's a fairly contained amount of time, 6 months or 12 months, but it's a fairly onerous and treatment with lots of side effects. So I'm kind of thinking about the family caregiver in that situation where it's time limited, 6 months or 12 months, and how we might think about that as somewhat different from Alzheimer's, autism, etc., which is really many, many years.
You know, family caregivers come in all shapes and sizes in many different situations. My experience happens to be with seniors, but as you saw from my slides, there are people caring for children and maybe a spouse with cancer, as you alluded to, and you know, there are commonalities across caregivers that regardless of the length of time they're caring for somebody, we all have the same basic needs, and sometimes even dealing with the, a short-term acute situation is just as traumatic as those of us who care for somebody long-term. But the needs across caregivers are the same. Did I answer your question? Yeah. Sorry, we're having a hard time hearing up here.
Yeah.
Yes, that was the question. If one would address this issue differently through technology or any other means for something that's fairly time limited and then might be, basically taken care of.
I think in some ways, I've been a caregiver, 2 instances, for very short term when my husband had surgery. I personally think being a caregiver is much harder than being a patient, but that's my personal view, so don't get angry with me. And because I had not sort of developed my caregiver skills, my caregiver coping mechanisms, my caregiver tips or tools in the same way that I have for dealing with my own illnesses, being a patient, it was much harder for me as a caregiver, and I would have loved to have had very quick access to what are the top things that you need to do when a loved one goes into the hospital or when you're bringing them home, or what are the key questions to ask. I realized, as experienced as I am as sort of an expert patient, I was a very inexpert caregiver and really needed the big lift of instant access to information and tools and mentors to be able to handle that very short period of time in the best way possible, because I didn't have the time to sort of build up that basis of knowledge.
And the problem is this knowledge base is scattered, if you will. There are a whole lot of organizations out there who have great intentions and are trying to do good things, but they don't work together. Let's not fool ourselves. So a lot of times the resources that you need, you have to go to many different places to find. And again, as I alluded to earlier, when you're trying to coordinate both healthcare, community support, social services, there needs to be one door for this. It is so not easy in either short or long-term caregiving situations to coordinate everything that you're going to need as a caregiver. And you have so many disparate resources that you have to go to, so many different doors to go through. We really need to change this paradigm.
And I think that's another part of the cultural change that I'm advocating between all the different sectors, even between, and you pointed out something very important, even between the associations, the advocacy organizations themselves. You know, one of the things as a leader that I push for on our website, on all of our resources, since we do have such high traffic and people are already coming to us looking for things, can we, if we are not the world-class leader in offering that type of resource or that solution or that answer, then we still need to connect people to it and not feel threatened by that. And so if another advocacy organization or a company or someone solves that problem for a patient or a caregiver, then we need to use our platform, our website, to help people find that and be connected to that sooner.
And I got to tell you, I'm a much more patient than I am a caregiver. When you're dealing with somebody, a family member who is ill, your patience runs thin really quick with a system that is not working with you but against you. So we really need to improve how we pull these resources together, who works together and why. Everyone needs to be working in lockstep to support both patient and family caregiver, keeping in mind that once that patient leaves a physician's office, a hospital, a rehab facility, guess what? There are a whole lot of family caregivers in there who are responsible for those next steps, and they're ill-prepared to help that patient in their journey to recovery. We need to improve that.
I see we have more questions at the microphone.
Yes, I'm Pat Hinton Walker from Uniform Services University. Good morning, Donna.
Good morning.
Hi.
I've heard you speak before, and both of you addressed issues related to the information you need to give. I'm going to back away here because I think it's loud. What I didn't hear you talk about, and I think, Donna, you've mentioned it before, about the recognition, valuing, and acceptance of the data that you have to give to providers, and some of the myths that are related to how consumers feel about e-health options.
Yes, I think the question, if everybody didn't hear it, was about, I think, at least the parts I heard, were about how to connect then caregivers and patients sort of activated to the providers. I haven't cracked that nut yet. I have a doctor's appointment tomorrow, so I'll try to work on it. But I use several apps to track my symptoms in real time, and I have found myself literally chasing my doctor around with my phone. Look at the graph, look at the trend, look at the app. And so I think that I would love to enlist all the people in this room in helping to acculturate providers to this new type of patient and caregiver who want to connect using mHealth solutions, and whatever needs to be done in the back rooms behind with the CIOs and those installing the EMRs and other systems to be able to fully integrate this new type of data and information into the official medical record, into the overall treatment plan. Otherwise, it's further fragmenting and further disconnected. Did I answer the question?
A year ago, I actually took a spreadsheet of my mom's medications to the inpatient rehab facility in which she was admitted. They refused to look at it. And trust me, it was accurate. They refused to look at it. There was perhaps a me versus them mentality going on in that facility, and it was very unpleasant. So we have to break down these barriers.
Thank you.
Another question?
Thank you. Thank you for two excellent talks, very elegant and informative. My name is Norm Dinerman, a physician, Eastern Maine Medical Center, Bangor, Maine. One of the things that my colleagues were talking about is the acute advocacy situation. I think, Donna, you alluded to it. You're in the hospital, doctor leaves, questions come up, you know, the V8 moment occurs. I could have asked that, I forgot, etc. Are you aware of any advocacy program that is focused on those acute hospital situations where we can help the caregivers? Or what questions would you ask in order to beget some type of system like that?
I know there are lots of books on that in print, those old-fashioned thing called books, and I guess you could download them as ebooks. The closest that I'm aware of personally is Tricia Torrey's blog on Every Patient's Advocate. But I think you bring out a very important point about how that needs to be integrated more into what the traditional advocacy organizations talk about and put out. You know, I recognize as I got ready for, you know, my 7th surgery 2 years ago that I prepared in a very different way than I did, you know, very hopeful, optimistically, lackadaisically, naively, 20 years before when I had my first surgery. So that information is needed, and I'll certainly share that with my advocacy colleagues. I think our time is up, but I see that there are still questions, so maybe we can take one more question.
Hi, I wear 3 very different hats, and I am a patient chaplain, a minister, and I serve as a chaplain in hospitals. I'm a health IT professional, and I'm a member of the Vice generation, where I have an elderly mother and I have a grandchild. And I think that what Ms. Sterling said earlier about there being so many disparate sources of information. For instance, on Medicare.gov is Home Health Compare, Dialysis Facility Compare, Physician Compare, Hospital Compare, and those all give you the quality ratings for these various institutions. My biggest concern as we move more towards mHealth is that we don't leave behind our target demographic of those that are getting older and don't necessarily have the savvy or access to this M world, but still need a lot of the information that's disseminated through the M world.
I think that's a very good point, and since our time is out, I'll simply say amen.
We agree.
To that. Yes.
Yeah.
Thank you, everyone.
Thank you.
And we'll be around for